There's a moment that happens in nearly every doctor's office in America, every single day, and almost no one talks about it. The patient is older, the appointment is running behind, the door opens, there are 14 minutes left on the clock, and in those 14 minutes, the system quietly makes a calculation about that person, one the patient will never see, never hear, and never be warned about. I know this because I spent 35 years on the other side of that door. I am not proud of everything I witnessed in those years. I am not proud of the moments when I was part of a system that moved too fast, assumed too much, and asked too little. And one day, near the end of my career, something happened with a patient of mine, something I have never shared publicly, something that still unsettles me in the quiet hours of the morning. It made me understand, more clearly than anything else in my career, why I had to make this video for you. I will tell you exactly what that was before this video ends, but I want to start with a mistake, not yours, the system's, and in some ways, mine too. The single most dangerous thing that happens inside medical offices and hospitals every week is not a surgical error. It is not a wrong drug. It is far quieter. It is a senior patient walking into an appointment without the right language, and walking back out having accepted whatever they were told. Because the current structure of medicine runs on that silence. It depends on it. I spent months going through the research behind this video, the kind of research that sits behind journal paywalls most people will never access. What I found was not just frustrating, it was genuinely alarming. There are 6 specific ways the medical system is failing people in their 60s, 70s, and 80s right now. Not out of cruelty, out of structure, habit, and assumptions that go unchallenged because patients do not know to challenge them. Today I am going to walk you through all 6. We will cover pain that gets dismissed as a normal part of aging, a symptom of a cardiac event that does not feel anything like what television has taught you to expect. Something deeply personal that most doctors are trained to overlook entirely, and more. There is also one question, just 4 words, that I believe is the single most powerful thing you can say inside an examination room. I am going to tell you exactly what that question is before this video reaches the halfway point. And I want to tell you about one specific document that I believe every person over 60 should carry to every single medical appointment for the rest of their life. It is not a medication list. It is not a hospital record. I will describe it completely before this video ends. This video will take about 30 minutes. The most important material is in the second half. Stay with me all the way through. And before we begin, I want to ask you something. Have you ever left a doctor's appointment feeling like something important was missed, or like something you meant to say never quite came out? Drop your answer in the comments below. I read every single one, and your answers shape what I make next. Let us begin. Most seniors are making the mistake of accepting pain as the price of getting older. And the damage from that acceptance runs far deeper than anyone has told them. You know this ritual. Before you even sit up in the morning, you are already assessing the day. How is the hip today? What will the back cost you? How much can you expect from the knees before they start protesting? You have done this so many times it has become automatic. You rate it silently, you arrive at some quiet verdict, and then you manage. And you tell no one. Not really. I heard that scene described to me hundreds of times across my career. I never asked about it nearly enough. That is something I carry. Chronic pain in people over 60 is one of the most undertreated problems in all of medicine. Not because effective treatments do not exist, they do, but because of something far more insidious, a belief held by too many clinicians, often without full awareness, that pain in older adults is simply what aging looks like, that it is natural, expected, that it does not warrant the same attention as pain in a younger person. A study published in the Journal of the American Geriatric Society in 2024 examined the pain assessments and treatment records of 15,809 hospitalized patients. The researchers found that older adults with geriatric conditions were significantly less likely to receive proper pain assessments compared to younger patients. And the authors pointed directly to what they believe is driving that gap. Many clinicians hold the false belief that pain is a natural part of aging, and may be more likely to disregard a senior's direct report of pain entirely. That finding should stop you cold. If you describe pain to your doctor and they hear it through that filter, through the lens of just getting older, your pain may not be taken with the urgency it deserves. It may not be taken at all. What is happening inside the body when pain goes unmanaged for months or years is not a neutral process. Pain is not just a sensation. It runs through a system of specialized nerve pathways that report tissue damage and distress directly to the brain. In a younger body, this system sends clear, specific signals. As we age, those signals become less precise. And here is what most people are never told. When chronic pain goes unaddressed for long enough, the brain and spinal cord begin to amplify the signal. This process is called central sensitization. It means that dismissing your pain does not make it smaller. Over time, it can make it more intense, more widespread, and harder to treat. The system turns up the volume when nothing is done. The consequences reach well beyond the pain itself. Undertreated chronic pain in older adults is consistently linked to accelerated functional decline, worsening sleep quality, significantly higher fall risk, and measurable cognitive deterioration. Pain is not separate from the brain. It is in the brain, every moment. And when it is not managed, the brain pays a price that no one warned you about. Here is where the conversation breaks down before it even starts. People minimize their pain when speaking to a doctor. They say things like, "It is not that bad," or "I am probably just getting older," or "I did not want to take up your time." Those phrases give a doctor everything they need to close that door and move to the next patient. What changes the outcome is a specific kind of description. When you go to your doctor with pain, I want you to describe it in 4 dimensions. First, the location. Not just my back, but exactly where, using your hand to point if needed. Second, the pattern. Is it constant or does it come and go? And what makes it worse or better? Third, the numerical rating. Be honest, not modest. A 6 is a 6. And fourth, this is the one that matters most, the functional interference. Tell your doctor precisely what this pain is stopping you from doing. I cannot walk to the mailbox without stopping. I have not slept through the night in 4 months. I gave up gardening 6 weeks ago. When you name a functional consequence, you make your pain real in a way that no number can accomplish on its own. A busy clinician can move past a 3 out of 10. They cannot move past your telling them you have not been able to pick up your grandchild in 6 months. Ask for a specific plan before you leave, not just acknowledgement. A plan for what happens next with your pain management. You are entitled to that conversation. There is a second layer of benefit to treating pain well that most people never hear. Those who get proper pain relief frequently report significant improvements in sleep quality within weeks. And in someone over 60, better sleep is one of the most powerful protective factors for memory, mood, and immune resilience. Treating your pain is not just about comfort. It is about keeping your whole system running at the level it deserves to run. You are not supposed to be in constant pain. Pain is not the entrance fee for getting older. It is a signal, and you deserve to have that signal heard. What I am going to tell you next genuinely worries me as a physician, because it happens every day in emergency rooms across this country, and most people over 60 have no idea it applies directly to them. If you found value in what I just shared, I want to pause for a moment and tell you something important. You probably found this video by searching for something specific, a symptom, a concern, a question your doctor did not fully answer. That means there is a real chance you do not yet know this space exists. I make new health information specifically for people your age every single week. Information your doctor may not bring up for months. To make sure you never miss a video, press the subscribe button just below this video right now. It takes one press, it is completely free, and it means this kind of information reaches you before you need it, not after. There is a video coming in the next few weeks on the warning signs your body gives you 30 days before a blood pressure crisis that most seniors miss entirely. That is the kind of information I want you to have. Press subscribe. Now I need you to understand something completely, because it may be the most practically useful information in this entire video. Your body, at your age, does not always announce a crisis the way the medical textbooks describe, or the way you have seen it portrayed on television for the last 50 years. You are sitting at the kitchen table one afternoon. You have finished lunch. A wave of tiredness moves through you that seems heavier than usual. There is something vague happening in your upper abdomen, not quite pain, almost like pressure. Your breathing feels slightly more noticeable than normal. Nothing is dramatic. Nothing screams danger. You sit for a while. It passes. You file it away under probably nothing and go about your afternoon. What I am describing could be indigestion. It could be fatigue from a poor night of sleep. But in someone over 75, It could also be your heart sending a warning in the only language it has left. As the body ages, the autonomic nervous system, the part that governs involuntary functions including heart rate and the processing of pain signals from cardiac tissue, undergoes significant changes. In younger people, a blocked or damaged coronary artery produces a clear, centralized chest pain. The signal is sharp and unmistakable. In older adults, particularly those over 75, cardiac nerve fibers become less efficient. What should arrive as chest pain may instead arrive as fatigue, jaw pressure, unexpected shortness of breath, nausea, or in some cases, nothing discernible at all. The body is still sending the warning. It is just sending it in a different language. A study published in the Annals of Geriatric Medicine and Research, analyzing medical records of 6,057 elderly patients, aged 60 and older, hospitalized with coronary artery disease across 4 university hospitals, found that nearly 1 in 4 patients, 24.8%, presented without the typical expected cardiac symptoms. Instead of chest pain, they arrived with sudden fatigue, general weakness, dizziness, confusion, and breathlessness. The likelihood of atypical presentation rose sharply with age. Adults 85 and older were 2.7 times more likely to present atypically than younger elderly patients. If you are waiting to feel a crushing chest pain before you call for help, you may be waiting for something that, in someone your age, may never come. Where this goes wrong for most seniors is twofold. First, they wait. The symptom does not match the expectation they carry from a lifetime of health education aimed at younger bodies, so they dismiss it and monitor it at home. Second, when they do go to a doctor or emergency department, they describe only the most recent or most prominent symptom, rather than the full picture of what has been happening across several days. The practical protection against this is simpler than you might think. I want you to spend 10 minutes this week building a short personal baseline inventory of what your normal feels like on a good day. What is your typical energy level from 1 to 10? What does your breathing feel like at rest? What is your usual digestion like after meals? What is your normal mood in the morning? Write this down somewhere you can find it, because when something departs significantly from that baseline, when you are at a 4 and you are normally at a 7, when your breathing at rest is noticeable and it has never been noticeable before, that departure is the signal, not chest pain, the change from your own normal. The same autonomic changes that can mask cardiac symptoms in older adults also mask the early presentation of serious infections. An older person developing sepsis may not develop the fever or chills that would signal danger in a younger person. They may simply seem more confused than usual, more tired, more off. If someone who knows you well tells you that you do not seem quite like yourself, not sick exactly, but different, please take that observation seriously. Someone who loves you may be reading your body more clearly than you are in that moment. What comes next in this video made me angry when I first fully understood its scale. It should make you angry too. Here is something that may catch you off guard, even after what you have just heard. The 2 problems we have covered so far, undertreated pain and missed symptoms, tend to develop slowly. They give you weeks, sometimes months, to catch them if someone is paying attention. What I am going to share with you now is the opposite. It is a harm that can happen within a single medical appointment, and most seniors have no idea it is building silently in the background of their care. Also, consider this. Most people believe that the medications most likely to send an older adult to the emergency room are the powerful or unusual ones, the drugs prescribed for serious or rare conditions. The research shows exactly the opposite. The medications causing the most hospitalizations in seniors are the most ordinary ones, the ones sitting in millions of pill organizers right now. Hold on to that as we go into the next section, because the reason behind it will matter for your safety. Picture every prescription bag you have picked up in the past year. Now set them all on your kitchen counter at once. For many people over 60, that counter fills up quickly. 5 bottles, 7, sometimes more. Each one was prescribed for a legitimate reason. Each one was given to you by a doctor who believed it would help. And all of that is true. But here is what the research shows is quietly happening in the background of that full counter. And it is one of the most consequential failures in modern senior care. A study published in the New England Journal of Medicine in 2011 by researchers at the Centers for Disease Control and Prevention, examining a national surveillance database tracking nearly 100,000 emergency hospitalizations of Americans aged 65 and older over a 3-year period, produced a finding that still stops me cold when I read it. Older adults are nearly 7 times more likely than younger persons to have adverse drug events serious enough to require hospitalization. Nearly 7 times. And the medications most commonly responsible were not exotic or experimental. They were blood thinners, insulin, diabetes drugs, and cardiac medications, the most trusted prescriptions on your list. The reason for this is something that clinical medicine does not explain to seniors often enough. Every organ system that processes and clears medication from the body changes substantially with age. The kidneys filter with less efficiency. The liver metabolizes more slowly. Body composition shifts, altering how drugs are distributed through tissue. The same dose that was appropriate at 60 may be meaningfully too high at 75. And when you are taking 5, 7, or 10 medications simultaneously, the likelihood that they will interact with each other in harmful ways grows in ways that no single prescribing physician can fully anticipate, particularly if you have more than one doctor, which most seniors do. This is the problem called polypharmacy. The word simply means taking multiple medications at once, typically 5 or more. And the way it causes harm is often not through a single dramatic event. It is through a slow accumulation, a fall attributed to unsteadiness that is actually being caused by 2 drugs interacting to lower blood pressure too aggressively. A confusion episode that gets labeled as dementia when it is actually a medication side effect. A hospitalization for something that appears to be a new problem, but is, at its root, the body struggling to process too many chemical instructions through systems that are no longer processing them the way they once did. The situation that leaves seniors most exposed is this. You may have a cardiologist, a rheumatologist, an endocrinologist, and a primary care physician. Each of them prescribes from within their own area of expertise. None of them may have a complete picture of what the others have added. The list grows, the interactions multiply, and no one has stood back to look at the whole thing. At your next appointment, ask your doctor specifically for a complete medication review, a systematic evaluation of every single thing you take, prescription and over-the-counter, to determine whether each one still belongs on your list, whether the doses remain appropriate for your current kidney and liver function, and whether any combination is producing interactions that may be harming you. If your primary physician cannot conduct this review fully, a clinical pharmacist, available at many larger pharmacy chains, is specifically trained for exactly this purpose. You are entitled to this review. It should not feel like an unusual request. One safety point that I want you to take seriously right now. Blood thinners and insulin are the medications most frequently associated with serious adverse events in seniors. Even small changes in diet, activity level, or the addition of any new drug, including over-the-counter pain relievers, can shift how these medications behave. If you take either of these, tell every single prescriber at every single appointment. And whenever any new medication is added to your regimen, ask specifically whether it interacts with your blood thinner or your insulin before you leave the office. There is an unexpected outcome that many people experience after a thoughtful medication review. When unnecessary or interacting drugs are removed from a regimen, people often describe their thinking becoming clearer, their sleep improving, their energy returning. What they had been accepting as the inevitable fog of getting older turns out, in some cases, to have been the accumulated pharmacological burden of too many medications running simultaneously through a body that could no longer handle them the way it once did. Some of what feels like irreversible decline may not be irreversible at all. What I am about to tell you next is something that, when I understood its full scope, made me genuinely grieve for the people in my practice who had suffered through it alone and in silence for years. You have stayed with me through a great deal of valuable material, and I want to take a moment to honor that. You have learned that your pain deserves to be named specifically and functionally, not minimized. You have learned that your body may be warning you of something serious through symptoms that do not fit the textbook description. And you have just learned that your own medications may be creating harm that has been building unnoticed. These 3 things are connected by something I promised you earlier. Do you remember the 4-word question I said I would share before the halfway point? Here it is. The 4 words are, What else could this be? Ask that question when your doctor gives you a first explanation for any symptom. What else could this be? It does not challenge their authority. It invites them to do their job more fully. It signals that you are not going to accept the first convenient answer and leave. Every doctor I have ever respected, when asked that question, slowed down. I watched it happen consistently across my career. The pace changed. The thinking opened up. Those 4 words, asked calmly and directly, are one of the most powerful tools you carry into that examination room. Now, the second half of this video contains the 3 things I worked hardest to get right. One involves a number of years that I believe will genuinely disturb you when you hear it. Another involves something so ordinary and so overlooked that it took a research team at a major university to finally put numbers on it. The most surprising finding in this entire video is still ahead of you. If this video has been valuable to you, please press the like button below right now. It helps other seniors find this information, and it gives you a way to find this video again easily when you want to share it with someone you care about. Keep watching. What comes next is what I most wanted you to hear. If you are not yet subscribed to this space, I want you to take care of that right now. I release health information built specifically for people in their 60s, 70s, and 80s every single week. The next video is going to cover what your resting heart rate is quietly telling you about your cardiovascular age, including one measurement your doctor is likely not watching that may be one of the most important predictors of long-term heart health in people over 60. Tap subscribe below. It costs nothing. It takes 1 second, and it means that video will find you automatically rather than you having to search for it in a moment of worry. There is a loss happening inside millions of seniors right now that is being called something it is not. It is being called slowing down, getting quieter, having less energy than before. And in some homes, it is being watched with quiet sadness by family members who do not know what to say because they have been told, and the person experiencing it has been told, that this is simply what happens. Let me describe something specific and ask you whether it resonates. The television is on in the evening. Nothing about the program is really landing. The things you used to look forward to, a call from someone you love, a walk outside, a book you kept meaning to start, feel more like obligations than pleasures. Food is not quite as satisfying. Sleep comes but leaves you tired anyway. You are functioning, but it costs more than it used to. And you are not entirely sure anyone can see what it is costing you. What I have just described is not normal aging. It is one of the most common presentations of clinical depression in adults over 60. And it is being missed, systematically, across the American medical system. A systematic review and meta-analysis, published in the Annals of General Psychiatry in 2021, drawing on global evidence about depression in older adults, reached a conclusion that every person watching this video needs to hear. Depression in the elderly is undiagnosed in half of all cases. Half. 1 in 2 older adults living with clinical depression is never identified, never treated, and never given the chance to learn that what they are experiencing is not the shadow of old age. It is a medical condition with real, effective, evidence-based treatments available right now. Think about who that number represents. It may represent someone you know. It may represent you. Here is what is happening biologically. The body's central stress regulation system becomes less efficient with age, leading to elevated levels of the stress hormone cortisol over time. Sustained high cortisol causes measurable damage to the hippocampus, the brain structure most associated with memory and emotional regulation. Simultaneously, there is increasing inflammation in brain tissue that disrupts the communication between circuits responsible for motivation, pleasure, and resilience. What the person experiences from the inside is not a breakdown. It is a slow, quiet dimming. The world gets flatter. Getting through the day grows heavier. And because the brain that would otherwise flag this as a problem is the same brain being affected, the person often does not recognize it for what it is. The reason doctors miss this so consistently is that depression in older adults presents completely differently than it does in younger people. In a 35-year-old, depression typically looks like visible emotional distress. In a 70-year-old, it may look like fatigue, loss of appetite, irritability, social withdrawal, or unexplained physical complaints. A clinician running a 15-minute appointment who is not specifically screened for depression will address those physical symptoms as physical symptoms and move on. And the depression continues, untreated, month after month. What keeps this hidden from doctors is something I saw endlessly in practice. Patients do not raise it because they believe the doctor is there for their body, not their inner life. That is one of the costliest misunderstandings in senior healthcare. Depression is as physiological as hypertension. It is rooted in chemistry, inflammation, and neural circuitry. It is not a personal failing, and in older adults, it is highly treatable. At your next appointment, walk in and say these words. I want to talk about my mood. I have noticed some changes that I think may be more than just getting older. Those two sentences open a door that would otherwise stay closed. And ask your doctor specifically to administer a screening tool called the PHQ-9. It is a 9-question instrument that takes 3 minutes and is the clinical standard for identifying depression. You are entitled to ask for it. You do not need to wait for it to be offered. Properly treated depression in older adults produces measurably better outcomes for every other condition they are managing. Heart disease, diabetes, cognitive function. The brain and the body are not separate systems. Lifting the depression lifts everything else. Tell me something in the comments right now. Have you ever been told that what you were feeling was just part of getting older, only to later realize it was something else entirely? Drop your answer below. I read every single comment on this video personally, and your experiences help shape everything I make next. You have now heard 4 of the 6 things I came to tell you today, and I want to give you a moment before we go further, because what is coming next surprised me deeply, even after 35 years in practice. Here is something most people do not know. The brain is so good at compensating for early damage that it can route around early losses in memory and language for months, sometimes years, before anyone on the outside notices. This is not a comfort. It is one of the reasons the next finding in this video is so striking. The brain can hide what is happening from the very person it is happening to. And there is something else waiting for you in the final point of this video. Something I am going to call the single most underestimated protective factor in senior medical care. It has nothing to do with medication, diet, or exercise. Most doctors have never prescribed it. The research on it is compelling, and I am willing to bet that almost no one watching this video is doing it consistently. You are in a conversation, maybe at dinner, maybe on the phone with a friend. You are mid-sentence, and the word you need is simply not there. You wait for it. It does not come. You substitute another word and move on. The conversation continues. Nobody says anything. Afterward, alone, you think about that moment. It happens again a few days later. A different word, the same pause, the same quiet substitution. You tell yourself, everyone forgets words sometimes. And you are right. The question is not whether you are forgetting words. The question is how long the medical system will wait before it treats that change as something worth investigating. A comprehensive scientific review, published in the International Journal of Geriatric Psychiatry in 2025, analyzed data from 13 studies conducted across the United States, Europe, Australia, and China, including more than 30,000 participants. The finding is this. From the first observable symptoms of dementia, it takes an average of 3.5 years before a person receives an actual diagnosis. 3.5 years. Sit with that for a moment. 3.5 years during which changes in memory, language, orientation, and daily function were present and observable. 3.5 years during which the medical system was not positioned to act. And 3.5 years during which conditions that can cause cognitive decline, some of which are reversible, may have continued their damage unchecked. Because here is what makes that delay medically critical. A meaningful percentage of what gets labeled as cognitive decline or dementia has a treatable underlying cause. Medication interactions silently blunting mental clarity, thyroid dysfunction slowing the brain's metabolism, depression presenting as memory loss, sleep apnea depriving the brain of adequate oxygen every night for years, vitamin B12 deficiency, gradually damaging the nerve pathways responsible for recall and processing speed. These conditions are not rare. They are common in older adults, and they are most effectively addressed when caught early. When the cognitive changes are mild and recent, not when they have become obvious to everyone in the room. Even in cases of true neurodegenerative disease, identification in earlier stages gives access to treatments that are most effective in those stages, allows for planning while the person is still fully capable of directing their own care, and preserves decision-making independence for longer. The case for early evaluation is not just clinical, It is deeply personal. The most critical place this breaks down is the wait. People wait until the changes are undeniable, until a family member is alarmed, until a hospitalization or crisis forces an evaluation. By then, the window for early action is often already closing. What I want you to do is bring the memory change to your doctor the first time you notice it consistently, not when it becomes obvious. At your very next appointment, say this: "I have noticed some changes in my memory and word finding over the past several months that I want properly evaluated." Then ask for a formal cognitive screening using a validated tool called the MoCA, the Montreal Cognitive Assessment. It is more sensitive than the older, simpler tests most clinics still default to. Also ask for your thyroid function to be checked, your B12 levels, a review of any medications with known cognitive side effects, and an assessment of your sleep quality. These are not extraordinary requests. They are the basic, appropriate response when a person over 60 reports changes in their thinking. There is something beyond the clinical benefit here, and I want to name it plainly. Knowing, even when the news is difficult, gives you agency. It lets you have important conversations while you can still have them on your own terms. It lets you protect your independence not by avoiding the risk, but by facing it early enough to prepare for it the way you choose. What comes next is the sixth and final point of this video, and it is the one I believe may have the largest single impact on the quality of your medical care from this day forward. Let me ask you to remember your last medical appointment. You walked into the office. You sat in the waiting room. You were called. You went in. The doctor entered. Questions were asked. An examination was done. Instructions were given. And then you left. Who was there with you? For a large number of seniors, the answer is no one. They arrived alone. They heard whatever they heard alone. They carried it home alone. And in the car on the way back, they may not have been able to recall the exact name of the new medication, or whether the follow-up appointment was in 4 weeks or 6. Or whether the doctor had said to take the new drug with food or without it. This is not a failure of memory. It is biology. Medical appointments are stress events, even routine ones. And under stress, the brain's capacity to encode and retain verbal information drops considerably. Research consistently suggests that patients, across all age groups, retain only about half of what is said to them during a medical visit. In older adults managing any degree of anxiety, cognitive load, or hearing difficulty in that moment, the retained amount can be substantially lower than that. A study published in BMC Geriatrics in 2019, examining the experiences of 40 companions who accompanied older adults to routine medical appointments, found something both straightforward and sobering. Companions consistently described the medical visit as a compressed, high-pressure environment, with almost no margin for confusion. They noted that the time available to extract and process critical health information was measured in minutes. When they were present, they acted as a second memory, a real-time interpreter of medical language, and an advocate for questions the patient had planned to ask, but lost confidence to raise when the moment arrived. When they were not present, that entire function went unperformed. The belief that costs seniors the most in this area is not about memory or confidence. It is the belief that bringing someone to a doctor's appointment is a sign of dependence. That needing another person in that room means something has diminished. That is a belief worth releasing entirely. Bringing a trusted person to a medical appointment is not a concession to weakness. It is one of the most strategically sound decisions you can make for your own health. When a trusted companion is present, several things change simultaneously. The stress response that narrows thinking and suppresses recall is modulated. Questions that might not have been asked get asked. Instructions that might have been misremembered get written down. And a physician, aware that someone is present who is paying close attention and will ask follow-up questions, tends to explain more thoroughly and more carefully. The specific action I want you to take from this section is this. Identify the person in your life who would take your health seriously, pay genuine attention, and feel comfortable speaking up if something was unclear. Have one direct conversation with them. Tell them you would like them to attend your next appointment, not as a caretaker, but as a second set of ears. Give them your medication list and the concerns you are planning to raise. Ask them to write down what the doctor says and to notice what questions did not get answered. If you do not have someone available in person, ask the practice whether a family member can participate by phone. Many offices now accommodate this. If you have no one nearby and need community support, patient navigation programs exist through senior centers, hospital systems, and community health organizations in most areas. These are trained individuals whose specific role is to accompany older adults to medical appointments. They exist, they are accessible, and you are entitled to use them. Bring a small notebook to every appointment. Before you go in, write down the 3 most important concerns you want to address. During the appointment, write down any changes to your care. Before you leave the room, read what you wrote back to the doctor and ask them to confirm it is accurate. That single habit changes the entire dynamic of the encounter. What this also protects is something fundamental. Every medical decision requires your understanding and your consent. You cannot give informed consent to something you did not fully hear. Having support in that room is how you remain the author of your own medical decisions, not just a recipient of someone else's. Now, let me give you the full practical plan, the one I would hand to a patient sitting across from me in my office after a conversation like this one. Everything I am about to say is new guidance, not a re-explanation of the science, just the specific actions, timed clearly. This week, make 2 things. The first is a symptom inventory. In a notebook or on your phone, write down every physical and emotional change you have noticed in the past 3 months that you have not told a doctor about. Pain patterns, fatigue levels, mood shifts, memory concerns, digestive changes, sleep disruptions. Write them all. Do not filter. The second is your full medication list. Every prescription and over-the-counter drug, including vitamins and supplements, with their doses. This list is the foundation of several conversations that need to happen. Before your next appointment, call the office in advance and ask for a longer slot than usual, 20 to 30 minutes if possible. Explain that you have multiple concerns to address. Most practices will accommodate this request when it is made ahead of time. If they cannot, schedule 2 appointments in close sequence. Prepare your index card. 3 things on it. Your most important concern for this visit. What you are hoping changes as a result of the appointment. And something you have been meaning to raise that you have been avoiding. Hand this card to your doctor when they sit down. Then watch what happens to the quality of the conversation. Confirm your companion. Tell them the date, what you are most concerned about, and what you would like them to pay attention to during the visit. At the appointment itself, when your doctor gives you any first explanation for a symptom, ask those 4 words I gave you at the halfway point. What else could this be? Ask for a formal medication review. Ask for MoCA cognitive screening if you have noticed memory or language changes. Ask for a PHQ-9 mood screening if anything in the depression section of this video landed for you personally. If you take blood thinners or insulin, ask specifically about interactions with anything new before you leave. And before you walk out, read your notes back to the doctor and ask them to confirm what you have written. In the week after your appointment, review your notes. Call the office to follow up on anything that was unclear or unaddressed. This is a completely appropriate use of the nurse line or the patient portal. Over the next month, if a medication review was initiated, follow up at 4 weeks to discuss the findings. If a cognitive screening was ordered, ask for the results in writing, and ask what the score means for your specific situation. In the 2nd and 3rd months, if you began depression treatment, whether therapy or medication or lifestyle-based, expect gradual change rather than sudden change. Most people notice meaningful improvement within 6 to 12 weeks. If nothing is shifted by 12 weeks, go back and ask for a reassessment. That conversation is both appropriate and expected. One important warning that applies to the people at most risk. If you take warfarin, any other blood thinner, or insulin, do not add any new supplement, including fish oil, vitamin E, garlic, or any herbal product, without confirming with your pharmacist that it does not interact with those medications. And be aware that grapefruit juice affects the way the body processes a wide range of prescription medications. Many seniors have never been told this. Ask your pharmacist directly which of your medications are affected. A month from now, imagine this. You have had a full medication review. One unnecessary drug has been removed. You have named your pain specifically for the first time, and a treatment plan is in motion. You brought someone with you to an appointment, and you remembered everything that was said afterward. Something has changed, and you did it by deciding that your health is worth showing up for fully. That version of you is not far away. It is one honest appointment away. I want to tell you something now that I have never shared in any video, never mentioned publicly, and have thought about more times than I can count in the years since it happened. Near the end of my career, I had a patient, a woman in her early 70s. She was sharp, present, quietly funny, and deeply proud of her independence. She came to me every 6 months with clockwork regularity, answered my questions efficiently, never complained about much, seemed, by every visible measure, to be doing reasonably well. I trusted that efficiency. I told myself it meant things were stable. I was wrong. What I did not understand, for more than 3 years, was that she was doing everything I have described in this video. She was minimizing her pain because she did not want to seem like a complainer. She was dismissing her fatigue because she thought that was just what 68 felt like. She was not naming the changes in her mood that had gradually settled in after her husband died, because she had decided that sadness at her age was not a medical matter. She was carrying all of it alone, very quietly, through every appointment, and I never asked the right questions. When she was finally hospitalized, not because of any single catastrophic event, but because of a slow accumulation of things that had each gone unaddressed for too long, I sat with her in that hospital room and asked her why she had not told me sooner. She looked at me with the particular patience of someone who has lived long enough to see clearly, and said, "I did not think you had time. I did not think you had time." That sentence has never left me. Not because it was an accusation, though perhaps it should have been, but because it told me exactly what she had internalized about her own worth inside the medical system, that her suffering was ordinary, that her changes were expected, that the doctor's minutes were precious, and her pain was not. She was wrong about that, and the system had taught her to be wrong about it. The struggles you carry every day, the pain you push through before you even get out of bed, the symptoms you dismiss because they do not match what you were taught to watch for, the sadness you have normalized because someone told you it was just the cost of getting older, the memory changes you have been watching quietly and hoping will not get worse. All of it is real, all of it is medical, and all of it is worth bringing into that examination room without apology. You are not too complicated. You are not too slow. You are not a burden. You are the reason the system exists, and you deserve to be treated as if that is true. The single most important thing I can offer you, after 35 years of watching people navigate illness, recovery, and everything in between, is this. The people who stayed well the longest, who kept their independence, who held on to quality of life further than anyone expected, were not the ones with the fewest health problems. They were the ones who refused to accept silence as an answer. Refused to accept silence as an answer. Tonight, not tomorrow, I want you to take one action that has nothing to do with medicine. Find a piece of paper and write down the one health concern you have been carrying quietly that you have not yet told your doctor. Just write it down. You do not have to act on it immediately, but writing it down takes it out of the category of private worry and puts it into the category of something that deserves attention. Because it does deserve attention, so does everything you are carrying. I am grateful you watched this far. Every year ahead of you is worth fighting for. Let me bring this video to a close with a brief, clear summary of everything we covered today. We began with chronic pain being systematically undertreated in older adults because of the false clinical assumption that pain is a normal feature of aging. The action is to describe your pain in 4 dimensions, including, and especially, the functional interference. What pain is stopping you from doing? That last dimension is the one that changes how a doctor hears you. We covered the reality that, in adults over 75, a cardiac event or serious infection may present without any of the classic textbook symptoms. Instead of chest pain, you may feel unusual fatigue, pressure in unexpected places, sudden weakness, or simply a significant departure from your own baseline. The action is to map your personal normal so you can recognize when something has meaningfully changed. We talked about polypharmacy and the nearly 7 times greater risk older adults face for hospitalization due to adverse drug events, driven by the changes in how the aging body processes medications. The action is to request a full medication review with your doctor or a clinical pharmacist. We covered the underdiagnosis of depression in older adults, unidentified in half of all cases, according to the Annals of General Psychiatry, and presenting not as visible sadness but as flatness, lost pleasure, and withdrawal that often gets mistaken for aging. The action is to walk into your next appointment and say, "I want to talk about my mood," then request PHQ-9 screening specifically. We covered the average 3.5-year delay between first symptoms and dementia diagnosis, and the fact that reversible causes of cognitive change are most effectively treated in their earliest stages. The action is to report memory or language changes to your doctor early, and request MOCA screening along with a thyroid and B12 check. And we covered going to appointments alone, and how having a trusted companion in that examination room changes what you hear, what you remember, what you ask, and ultimately what happens to your health. That one change may produce more improvement in your ongoing care than anything else on this list. And here is the document I promised you at the very start of this video. Not a medication list, not a diagnosis record, a single index card with 3 written sentences. What my main concern is today, what I am hoping leaves this appointment differently, and what my doctor should know that I have not yet found a way to say. Bring that card to every appointment. Hand it to your doctor when they sit down. It takes 10 minutes to prepare, and it changes the entire quality of what happens next. Before I go, one warm question for you. Has your doctor ever told you that something you were experiencing was just a normal part of getting older, only for it later to turn out to be something treatable? Leave your answer in the comments. I personally read every one. And here is what is coming in the next video. We are going to look at what your resting heart rate is quietly revealing about your cardiovascular age, including one number that most physicians do not watch closely, but that research suggests may be one of the strongest predictors of long-term heart health in people over 60. To make sure YouTube sends that video directly to you, press subscribe below right now. It is completely free, it takes 1 second, and it ensures that this kind of information reaches you before you need it. One final note from me as your physician. Everything in this video is educational. Before making any change to your medications, your screening schedule, or your health routine, please speak with your own doctor first, especially if you are currently taking blood thinners, heart medications, diabetes medications, or any other prescription drug. Your physician knows your personal history in ways I cannot from here, and that context always matters. What I hope you leave with is the certainty that you are allowed to ask questions, insist on real answers, and expect to be treated as the most important person in that room. Because you are. Thank you for watching. I will see you next week.